look at the pathology findings. First, we have our colon biopsy, and this is a low-power picture showing well-oriented colonic crypts with preserved mucin and lamina propria expansion, apparently by inflammatory infiltrate, and no erosions seen. Here we have a higher magnification, which shows mixed lamina propria infiltrate with no significant crypt insult, and we also see some congestion. Here we have another high power field showing the same features with focal cryptitis and scattered pigment-laden macrophage. And so we started thinking, could this be hemosiderin because of congestion and hemorrhage? Could this be melanin, as in melanosis coli, or could it be something else? Now we move on to our excisional lymph node biopsy. On the left, we have a low power view. On the left, we have this low power view, which shows focally preserved nodal architecture with follicular hyperplasia. And on the right, we can see another view showing few scattered, non-necrotizing histiocytic granulomas seen at the periphery. The hallmark pathological feature here of the lymph node was multiple expanded histiocytic granulomas with central suppurative type necrosis. Here, a higher power magnification, which shows the histiocytes palisaded around central necrosis. And here, another higher power view on necrosis showing its suppurative, non-caseating nature with many neutrophils and tissue debris. So now, should immunohistochemistry be done? Our choice was no. In order to approach this case, now we have to consider the different causes of granuloma in children, which are divided into two main categories, infectious causes and non-infectious causes. And under the infectious causes, we have TB, fungal infections, cat scratch disease, toxoplasmosis, as well as some other infectious causes. Under the non-infectious causes, we have Crohn's disease, foreign body granulomas, sarcoidosis, immune deficiencies such as chronic granulomatous disease, lymphomatoid granulomatosis, and autoimmune disease. So now, are we ready to conclude our pathology reports? If we're going to write a report, the colonoscopic biopsy will be reported as focal active colitis with pigment-laden macrophage, no features of IBD, no dysplasia, and no malignancy. And the cervical lymph node excisional biopsy will be reported as a necrotizing granulomatous lymphadenitis with no evidence of lymphomatous infiltrate. With a comment to the clinician for the possible causes of granuloma. Now, should we move on to the next case? Actually, no, not yet. To obtain further information, we could either call the physician, conduct an MDT meeting, or use the hospital information system. For this case, we decided to contact the pediatrician, and now let's imagine this call together. Hello, Dr. Pediatrician. Hello, Dr. Pathologist. Well, we have this case, a 1.5-year-old boy, and we have those histologic findings. Any specific tests done? Yes, we suspect immune deficiency. Viral markers are negative. Some immunoglobulins are abnormal. TB quantiferon gold test is negative. And the case is for whole exome sequencing to exclude any genetic-based disease. And we did some extra tests, including the dihydrorhodamine test. Okay, please give me feedback with the results. Yes, sure. But do you think this is TB? No, it is not. Thank you, doctor. So our concept here is a holistic diagnostic approach. We have our clinical data of recurrent infections and lymphadenopathy. We've received the test result for the dihydrorhodamine test, which turned out to be positive, and we will talk about this test later on. And we have our pathology reports showing a granuloma in the lymph nodes, granulomas in the lymph nodes, and pigment-laden macrophage in the colon. And with that, we reached the final diagnosis of chronic granulomatous disease, or CGD for short. Here, we have received the result for genetic testing, which showed a gene mutation in the CYBA gene in an autosomal recessive inheritance pattern. And this slide shows a continuation of the report with a recommendation to inform the family members of this mutation. So, what is chronic granulomatous disease, or CGD? CGD is an inborn error of immunity, a type of primary immune deficiency disease in which phagocytes are unable to kill many types of bacteria and fungi, leading to serious infections. This phagocyte dysfunction is due to mutations in one of 5 genes that code for proteins of the enzyme NADPH oxidase, seen at the top, the NADPH oxidase complex in the picture, which is important for producing ROS, or the respiratory burst, by phagocytes in order to kill bacteria and fungi. We have 2 inheritance patterns, an X-linked recessive inheritance pattern and the mutation here is in the CYBB gene. And because it is X-linked recessive, it is much more common in males than in females. And the autosomal recessive pattern in the CYBA, NCF1, NCF2, or NCF4 genes. And this inheritance pattern occurs equally in both males and females. CGD is a rare disease occurring in around 1 in 200,000 to 1 in 250,000 people worldwide. CGD falls under the umbrella of primary immune deficiency diseases, or PIDD, which are classified according to the cell or immune component affected. And here in our case, chronic granulomatous disease falls under the phagocytic disorders. The diagnosis of CGD can be done based on, number 1, the clinical suspicion through the characteristic features, clinical features such as the recurrent infections and lymphadenopathy, or a positive dihydrorhodamine or nitroblue tetrazolium tests, which are phagocytic function tests. Regarding the nitroblue tetrazolium test, functioning cells normally will give a blue color. In CGD, it does not. And regarding the dihydrorhodamine test, normally after stimulating neutrophils, a change in fluorescence will occur, which is detected by flow cytometry. And here is a graph showing the unstimulated side on the top left, and on the top right, normally after stimulation, there is a shift of the graph to the right, indicating increased fluorescence intensity, whereas in CGD patients, cells are non-functioning, no stimulation, no change, and no shift in the graph. We, of course, now have the pathological examination findings, such as the non-caseating granuloma, which we've seen in our case in the lymph node. However, it could be necrotizing, as we've seen in our case as well. And the granulomatous reaction occurs due to the continuous recruitment of macrophages due to inefficient elimination of antigens. And of course, we have the pigment-laden macrophage, which occur due to inadequate digestion of debris, mainly lipofuscin bodies formed from lysosomes. This is a picture showing PAS positive staining of these pigment-laden macrophages, which would not occur if the pigment was melanin or hemosiderin, and this is an actual picture from our case. And of course, finally, the confirmatory test, the genetic testing. So, can we fix this error? Currently, the treatment is lifelong prophylactic antibacterial and antifungal medication to prevent future infections. And in some cases with severe infections, interferon gamma injections may be given. But yes, the error can be fixed, and some patients may achieve cure with stem cell transplantation. And this is actually the treatment given to our patient in this case. And currently, gene therapy is also being researched. So, our take-home messages for today. Granuloma is not always TB versus sarcoidosis. Some other differentials must be thought of as well. And communication and multidisciplinary team discussions remain the gold standard approach to reaching a conclusive diagnosis. These were my references for today's presentation. And thank you very much.
Thank you, Dr. Malak, for this great presentation.
Thank you, Doctor.